I'm pleased to get a chance to introduce our next speaker in here, Dr. Jeff Schiff, who's going to be talking about using data to improve patient-centered outcomes, a view from the Medicaid Medical Directors perspective. You have his biography in the notes in here, and I'm not going to read the entire thing because I want to give him as much time as possible. I just wanted to say a couple of things about Dr. Schiff. He is a medical director for the Minnesota Healthcare Program at the Minnesota Department of Health Services. This includes Minnesota's Medicaid, General Assistance, Medicare, Medicaid, Medical Care, and the S-CHIP program, Minnesota Care, and the Division Director for the Health Services Medical Management Division. He is the current chair of the Medicaid Medical Directors Network, and in that capacity he directs a 22-state project to measure the status of early elective delivery in these states. He's also chaired a PCORI advisory group to identify perinatal project topics to be considered for future funding. And with that, I'd like to turn it over to Dr. Schiff.
Thank you all, and as other folks have said, it's quite an honor to be here. So I want to take you on a little data journey as soon as I figure out how to do this. And a couple things. I want us to be impatient about this because this is a fascinating time, and I think if we can be a little impatient and a little persnickety about this and be a thorn in a bunch of people's shoes, we may be able to move forward. My story is really about trying to link data and policy and the journey that took us on. And I want to just start by saying that I always talk to folks about data and stories because legislators and all of us, quite honestly, I think react to stories more than data. So I love it when I can tell a story about data. But the data actually, what I also want to say is what I find at the Medicaid level when I'm trying to get through to legislators or other policymakers is that a little bit of data goes a long way. The way it was displayed from Maryland or a few facts so you can really drive home if you want to. And then linking the data with individual stories I find is often a very effective way. And at the legislature where they're very often moved by stories, it's always good to bring the data but bring a story with you, somebody who's been affected. So I'm optimistic because I'm by nature optimistic, but also because the data is our chance to be optimistic, and if we can get the data to be used well, we can make a difference. Some takeaways I'd like to leave you with today, because what I really want to talk about is the story about a nationally organized, state-led quality improvement effort. Is that measurement and quality improvement have to be relevant to families and frontline providers, and that's really how to keep it sustainable and how to drive it. State-level quality improvement can be and should be linked to policies that the states actually make, and I'll talk about Medicaid policies. And then data and quality improve together. One of the things I often hear, as I'm sure a lot of you do, is, well, the data is not good enough. Well, the data will never be perfect, and we have to make decisions based on the data we have. And then the last thing I just want to talk about, which is shameless advertising, is that we need resources and infrastructure for doing this kind of work. So who are we? The Medicaid Medical Directors are a group that's been meeting since 2005. We started as a knowledge transfer project of the Agency for Healthcare Research and Quality, and now have come under our new home in the National Association of Medicaid Directors. We have a motto we use all the time, which is to steal shamelessly and share senselessly between our states. And we have goals. Our goals of the network are, first of all, just to maintain ourselves. It's sort of breathing before eating, that we have to exist. And then we'd like to represent our collective viewpoint on panels like this or at the National Quality Forum. And then we have a lot of discussion in our network now about how to do collaborative work in the Medicaid between states. Our vision in our bylaws is to improve the lives of Medicaid patients through excellent health stewardship. This is who we are on a daily basis. We are a bunch of folks out there trying to shoot the rapids and trying to get policy done in a very interesting place. And as a network, I think this is a more fun slide. This is who we are. We'd rather ride together than solo, but the reality is that we sit at the juncture of practice, policy, and payment. And because this is a time when there's a ton of talk around behavioral health integration and population health and healthcare, it's a really important time for a group like ours, we believe. We've done 3 projects that we think are of national significance to look at, to use Medicaid data and to compare state Medicaid data. And this is the story I want to tell you in just a few minutes. We did a project to look at antipsychotic medication use in children. We did a project on hospital readmissions, and then the project that I was involved in was early elective deliveries. The antipsychotropic medication use, we got 16 states together. I'll talk about how we did that, and looked at the pooled analysis from 16 states to talk about the use of antipsychotic prescriptions. And some of the stuff from this project sort of has had echoes for a long time now. It's been something that's been cited with the Agency for Children and Families to look at the psychotropic medication use in foster care kids. It's stuff that we actually look at in individual states as well. And my state, although is not one of the 16, we actually have policy and work going on around this. The second project was on hospital readmissions, and Judy Zerzan, who's my partner in crime from Colorado, is here, and she and David Kelly from Pennsylvania led this. And this is data on readmissions. We had looked at 30-day readmissions and saw that 9.4% of all of our admissions were 30-day readmissions. And for this group, I just pulled out a little bit of the data from that paper to say that 10.9% of the children aged 0 to 12 who had a behavioral health readmission, and 11.7% between 13 and 20 had a behavioral health readmission. And that's, in Medicaid, that's obviously real dollars. So I'm going to talk more in detail about the story that I know best, which is about early elective delivery and why we chose this project. We chose it because a little under half, by a hair, of all births in America are paid for by the Medicaid program. And because there's a lot of things going on with birth that affect the health of children, and for this group, some of those effects are associated with behavioral and cognitive and developmental issues. The issues around early elective delivery are pretty clear. Everyone knows it's not supposed to happen. The American College of Obstetrics and Gynecology said that. Having it not happen is part of the Medicaid adult core set. The HRSA and the MCHB have picked this up, and the CDC National Center for Health Statistics is interested in having that data used in a productive way. So we decided that there are a few other things about this that's different in some ways than some of the data we can talk about for this group, is that it's easy to identify. It's relative to other things. There's a clear literature on effective interventions around hard stops. Improvement can be tracked. It's relevant to both the families and frontline providers, and relevant to policymakers. So we set about these projects, I think, both to do the project, but also as a proof of concept. Organizationally, we want as Medicaid medical directors to get enough folks on board. And the proof of concept is that this work can be done as a state-led national project. For this project, we tapped into quite a few federal agencies to ask for support. We also had relationships with all the national organizations that we could identify that were associated with early elective delivery. And then we went to our state partners as well. Actually went to the state partners first and saw if they were interested. And Academy Health served as our project organizational home. The other thing I'll say about this as far as proof of concept is that the projects that we've done have been, I tell people that they've been held together by bubblegum and baling wire, because it's really about how to get the right people in the right place to get this to happen. But What we did first is we went to the other Medicaid medical directors, and we first looked for input. We looked for something in the birth space that was important and actionable. And then we defined the parameters with the data staff from the states. And I think a little bit of what we did, which I think, or a lot of what we did, which I think is really important, is we got closer to comparative data between states. And we got to the point where states could actually say, our data is more comparable to other states, so we could actually see what the differences in variation is. We set up data submissions and gave technical assistance to states around that. This is something that states aren't inherently good at, but the medical directors and the data staff are really interested. One of the things that's really fascinating for me is that this charges up the data staff in Medicaid. When you can go to your data staff and say, do you want to work on a project and compare how Minnesota's doing with what other states are doing, they're like, yeah, that would really be cool. And then when you get them on the phone together and they get to see just little comparisons about how things like, how do you decide on a Medicaid eligible birth? How do you decide, how good are these fields filled out on birth certificates? People get charged up because they want the data that they're looking at every day to be useful. Anyway, we did that. We have a data analysis capacity that we used, and then obviously reports were important. Our main results I'm not going to tell you because they're coming out in a month, and so I've been embargoed, but I will tell you that the number of early elective deliveries is significant, and the number of elective deliveries is also significant. And I will just remind everybody here that there's been some associations with early elective deliveries that are important, including cognitive outcomes and ASD outcomes. So, just a couple things I want to re-emphasize that I said. A couple key features of the projects we've done is we share our results with the states. Each state owns its own results. So this is a quality improvement program at the state level. So our goal here is not to have states publicly outed for whether they're good or bad. Our goal is to have states look at improvement over time and to see where they're at and to be able to compare policies of where they're at now. And we measure variation in that way. And I think that's a really very powerful point, because just like we try to do in Medicaid at the provider level, when we go to hospitals or provider organizations, we say to them, what's your variation? Or go to counties and say, what's your variation? Looking at variation and allowing people to act on their own variation drives improvement in a way that's very productive. And getting folks involved at the state level or at the local level in this actually creates ownership, and I want to really emphasize that. So very quickly, I want to just talk about some of the steps in developing this. What I really want, first of all, and Sarah Scholey is here, so she can talk about this better than I ever will be able to. There are a lot of steps in measured development, and this is from an article that just came out from Elizabeth McGlynn in JAMA, or an editorial. And these are all the criteria of what makes a measure workable. But I think the important thing that I think sometimes in this link in the chain is the quote at the end. The challenge with many outcome measures is that evidence about how to improve those outcomes is lacking, and that by the time serious outcomes occur, the opportunity to improve care for those patients has been lost. So we have a challenge around that. We actually look at measure adoption in Medicaid, and we talk about measures and what gets measured gets done is what we always hear. But then we also talk about measurement fatigue, where we get told over and over again that there's a zillion measures out there. So this is all really an argument for involving the people who are getting measured and the people and the end users in the measures, because that's where the measures will really take off. We have in Medicaid, and one of the things we did in this project and was already talked about very well with the folks from Illinois, is we talk about data linkages and the challenges of data linkages. Our records exist at Medicaid, and they are claims, which are service use, and encounter data, which is what comes in through managed care. And then we also have enrollment data, which can include things like race, level of poverty. Our challenges around linking are things that have to be overcome, and I was really fascinated to see the example in Illinois about how they did that. But we have to match records, we have to decide on identifiers. Deciding just on the process of linking data is quite a challenge. And in our 22 states, 12 of them used linked birth certificate and Medicaid claims data. And of those, the processes by which all of those linked were really very different. And then the roles, who's actually doing the linking, where's the data live after it's linked, and who owns the relationship of the data to access. And I think all of those things have to be addressed. But what I'll tell you about this that I think is really something to be optimistic about is if you get the data people involved and they tell them what the data is going to be used for, they'll push with you to get that done because they're excited about this as well. And then the availability of data is the other thing that's hard on linked platforms because timeliness is really an issue. Presenting data to providers 15 months or 18 months after the data has already been collected isn't always actionable. And data that may be of lesser quality, for example, the rate of first-time C-sections that could be done every quarter to a hospital may be way more worthwhile, even if it's not perfect, but can trend over time, than something that we think is more perfect. So I think we have to always think about those compromises. A couple other things about data linkages. Common definitions have to be same in comparative systems. We had a project in Minnesota that we were looking at the well child check use in our foster care system through our social security, through our social services system versus our Medicaid claims, and the definitions are different in those things and they have to be reconciled. Changing definitions are an issue. As we know, DSM-5 has different definitions for a lot of things that have made us put a big asterisk in some of our data. And then I just want to talk about opportunities in data linkage because I think it's so important. The linkages provide us an opportunity to improve all of the data. We have an opportunity with linkages to start thinking about incorporating patient-reported outcomes into the data. And how we collect patient-reported outcomes is something we should talk about as well. And then, of course, meaningful use and health records. And we just talk about even little steps along that, like knowing whether or not someone's BMI is available would maybe help a lot for monitoring some things. So I guess just a couple things here. We use measures in Medicaid for quality improvement and for policy development. I think I talked about most of this already, but some of the things that I think are really important I just want to emphasize here are around addressing disparities and around using patients to improve the healthcare system. We have in different parts of the program in Medicaid the history of using patients and engaging patients and families in the systems, and they ask different questions, and I think we ought to make sure we emphasize that. So that's my story about, at a very high level, about how we used data with the Medicaid medical directors and how we try to integrate the quality improvement at the state level. I just have a few things I wanted to share here, and these are about what topics could a group like this consider in the same kind of setting. And this is just a little bit of brainstorming I did with some of my own staff. You probably could create a list that's even longer than this. But I think that one of the things I challenge you about is to think about how to engage Medicaid, how to engage the Medicaid programs, and what the claims and the encounter data that we have could do to help look at variation. And one of the things, these are all just topics that could easily be considered, and I think that there are obviously a lot more. As I was sitting here at the first presentation, I thought, what about just diagnostic variation? So the last thing is my shameless advertising, and that's that to do projects like this, there's an infrastructure that needs to be developed for project development, for the process steps around data definitions, analysis, et cetera. Staff time at states is always stretched thin and always subject to the political pressures of the state, but that's really important. And then integrated support and network maintenance is really important to keep these things going. So, nationally organized, state-level quality improvement can be done. These are the things I think that need to happen to make it done. And last, I have to leave you. I've been talking fast because I've been trying to say a lot, but last I have to leave you with a thought, and that's that every program needs a superhero. I'm voting for Elastigirl. The reason I wanted to talk about this is because those of us who are in this role in states stretch from knowing what the frontline providers are, or being frontline providers ourselves, having direct contact with families and knowing what's going on, to being able to have the honor of coming and talking to forums like this. So knowing the breadth of this and knowing how important it is to vertically integrate these measures to improve, my nomination was Elastigirl. So thank you very much.